Welcome to Wednesday morning rounds. Please sign up for rounds for next week. We'll have some guests from the critical care team talking about the advanced care planning program. So please attend next week. This morning, it's my pleasure to introduce one of our cardiology residents, Dr. Pouya Motazedian. He's in his final year with us, and then he's going to go on to do some critical care training. So welcome, and he's going to talk to us about weathering the electrical storm, given the current weather. Oh,
So thank you and good morning, everyone. I'm excited to discuss electrical storm this morning. Now, before going into the presentation, one of the main themes that really comes up is that with electrical storm, we have a pretty limited evidence base. And I think this is partly related to a few things. One being that there's challenges in how we define the electrical storm patient population. And two is that these patients are often critically unwell, and it makes completing clinical trials quite challenging. So often we rely on expert consensus or previous experiences to guide our clinical management and guideline development. In terms of the outline for today, we'll be discussing the spectrum of ventricular arrhythmias and electrical storm, the pathophysiology and evidence-based management, and then finally we'll discuss some of these studies here at the Heart Institute. So ventricular arrhythmias are classified in a number of ways, one of them being based on the number of events that occur. ICDs have been used to treat ventricular arrhythmias, abort sudden death with improved patient mortalities. In the case of a patient who hasn't had a previous event, who's high risk of having an event, a primary prevention ICD can be implanted, and those with previous ventricular arrhythmias can have a secondary prevention ICD implanted. Now, as some patients have more ventricular arrhythmias, they meet this threshold called clustered ventricular arrhythmias, being that they've had at least 2 episodes in a 3-month period. And why this is important is that it's associated with significant mortality. So this is a sub-study of the RAFT trial, which looked at the use of CRTD in patients with systolic heart failure. And as you can see in this solid black line, being patients who haven't had any arrhythmias versus those who have had any sort of ventricular arrhythmia, there's a significant reduction in mortality. But then the solid gray line beneath is those who have had clustered arrhythmias and not even electrical storm, and their prognosis is even much worse. They also did some interesting sub-analyses where they looked at the cluster length, or the cluster duration, meaning the time from their first ventricular arrhythmia to the time to the last ventricular arrhythmia. And what they had noticed is that as you decrease the cluster length from 90 days to then down to 24 hours, there's an increased risk of mortality associated with it. Furthermore, for a pre-specified cluster duration being either 24 hours, 3 days, or 7 days, or etc., as you increase the number of ICD therapies, you also increase the risk of mortality. Now, there's a couple important or a couple of key points to highlight here is that this applies to both patients who have received ATP and ICD shocks, more so for those who have received ICD shocks. And then we're also talking about mortality. We're talking about long-term mortality. So the follow-up for the RAFT trial was over 2.5 years. And we're not really commenting on the short-term mortality that we think of with a condition like electrical storm. So what differentiates clustered ventricular arrhythmias from electrical storm is that electrical storm is a medical emergency. You'll see this often highlighted in clinical guidelines and consensus documents. And in broad terms, electrical storm then becomes a form of densely clustered ventricular arrhythmias, meaning many events over a very short period of time that has significant short-term mortality, being that it is a medical emergency. Now, practically speaking, we don't use that definition. We use an electrical definition, meaning number of episodes over an X period of time. And when higher risk recurrent ventricular arrhythmias were first studied, before it was called electrical storm, there were a number of different definitions used. And I do want to bring particular attention to 3 studies that were published in the 90s. The clinical trials published by Drs. Levine, Scheinman, and Cowie were the first trials to look at the acute treatment of recurrent VT and VF. Their study population included those who had 2 or more episodes of hemodynamically destabilizing VT and VF in a 24-hour period, and those who were also refractory to initial antiarrhythmic drugs, including procainamide and lidocaine. And what they had found is that this patient suffers from a very high short-term mortality, with their 48-hour mortality being between 15 and 25%. So when I think about electrical storm, this is the patient population I classically think of, and I think it's what a lot of us probably think about, is that it's a patient who has lots of ventricular arrhythmias in a short period of time, and it's a patient population that has very high short-term mortality. And the Canadian guidelines at that time had agreed with that sentiment. And they had published a guideline document defining electrical storm as having 2 or more episodes within a 24-hour period. Now, this guideline document came out in 1999, and we've had a little bit of an evolution in the change, or a little bit of evolution in the definition of the electrical storm, going from 2 episodes to 3 episodes every 24 hours. And there's no clear reason for why this change has happened. But there's a couple of considerations. One being that we've had an evolution with ICD devices and the integration of ATP. So if someone has had 2 episodes of ATP in 24 hours, is that really deemed a medical emergency? So maybe by increasing that threshold, we're picking up a sicker patient population that we classically think of being as electrical storm. And 2 is that around the time when this guideline came out and some of the studies that were published thereafter, they would use the cutoff of 3 episodes per 24 hours. And this, again, was in observational studies, not in clinical trials. And this cutoff seemed rather arbitrary, but this is the definition that stuck. So with the increase in threshold to call a patient or to diagnose electrical storm, we're still anticipating an acutely sick patient population. But this doesn't really seem to be the case. So in the most contemporary clinical trial that we have in propranolol versus metoprolol for the treatment of electrical storm, there was no deaths after 3 months of follow-up. So what's changed? One, it could be related to the evolution of patients over time, specifically electrical storm patient population. 2, again, it could be the evolution of ICDs and their therapies. And then 3, just general improvements in cardiovascular care. But there is also some key differences between the original studies that were published and the most recent. So in the original studies from the 90s, none of those patients had ICDs. All the patients need to have hemodynamically destabilizing ventricular arrhythmias, and all those patients were refractory or intolerant to initial antiarrhythmic drug therapy. Versus the most recent and more contemporary clinical trial, all the patient had ICDs, and that key inclusions of what I believe are high-risk patient populations or subgroups, being those representing with acute MI, decompensated heart failure, those who are hypertensive, and those who have end organ dysfunction. So what we have essentially, or what's been essentially done with the definition of electrical storm, is that we've created a pretty heterogeneous patient population where there is patients with low risk, or what I like to think low risk electrical storm, meaning that they have a low mortality and are likely to respond to first-line therapy. And those who are high risk electrical storm, meaning that they likely suffer from high mortality and they're refractory to first-line therapy, or are more likely to be refractory to first-line therapy. And as a result, what this has practically meant in terms of our definition of electrical storm is that these patients are not guaranteed to suffer from short-term mortality. It's a potential risk given how heterogeneous the patient population is. Now, shifting gears here a little bit, I do want to talk about the burden of disease. In a review that was published in 2021, they included this nice table that looked at many of the observational studies that followed patients with ICDs, and the incidence of electrical storm. Given that the ICD patient population are the patients who predominantly develop electrical storm, we can see that up to 60% of patients will develop electrical storm with ICDs, but with more contemporary data, the numbers are between 5 to 10% and 20%, depending on if you have a primary or secondary prevention ICD. When you combine this with the fact that we're implanting more ICDs over time, patients with ICDs are living longer, the absolute number of electrical storm cases have increased over time. So just to summarize what we've discussed so far, electrical storm is a common condition that we now see in CCUs and ICUs. The current definition of electrical storm really captures a pretty heterogeneous patient population. And as we've already seen, the threshold for diagnosis is rather arbitrary. And there's a bit of a discrepancy between what we picture electrical storm being, or what the classic thought of electrical storm is, and what we see in practice. And lastly is that an evidence-based definition or some sort of risk stratification is likely required to better distinguish the severity of electrical storm. From a trial perspective, this is pretty important just because it becomes challenging to create clinical trials with high internal validity when you have such heterogeneity in the patient population. Now, moving forward to the pathophysiology. Electrical storm is thought to result from a triad of acute trigger, vulnerable substrate, and autonomic dysfunction. As you can see on the figure on the right, the involvement of each component can be variable and differs between patients. In terms of vulnerable substrates, this is generally categorized as patients have a primary myocardial pathology or a primary arrhythmogenic pathology. By far, the most common substrate is ischemic heart disease, which is probably found in at least 2/3, if not even higher, closer to 80%, depending on the reference that you look at. Non-ischemic heart disease, such as dilated cardiomyopathy and hypertrophic cardiomyopathy, are also common, along with inflammatory cardiomyopathy, such as sarcoidosis and myocarditis. Channelopathies we see less of, but we do see them every once in a while. In terms of an acute trigger, it's often an acute illness. An electrical storm can be further classified as being a primary arrhythmic event, meaning that there is no acute triggering event or triggering illness, or a secondary event related to some sort of acute illness that's going on. In the SHIELD trial that looked at Asmolide for VT suppression in patients with ICDs, those who had developed electrical storm, 15% were found to have some sort of acute trigger or illness. So the predominant patient population is still one of primary electrical storm. Now, the most common trigger is acutely decompensated heart failure. But other common triggers include ischemia, which in the era or in the pre-revascularization era by far was the most common trigger. We see it less often now. And then things like infection, electrolyte abnormalities, medications, toxins, ingestions, and withdrawal are also common triggers. Autonomic dysfunction has been an area in electrical storm that's looked pretty promising. There's been lots of interest in it. And this is a result of an imbalance between the sympathetic nervous system being hyperactive and dysregulation of the parasympathetic nervous system. And this can happen acutely, like in the setting of an MI, but can also happen chronically in the context of having a chronic coronary artery disease or systolic heart failure, or any heart failure in general. In the example of systolic heart failure, though, these patients are often found to have 50 times the amount of circulating stress hormones compared to patients with structurally normal hearts. And what happens with the imbalance between the sympathetic and parasympathetic nervous system is that it results with a excitable myocardium that then increases the risk of developing ventricular arrhythmias. And this leads to a key concept of VT leading to more VT. So in patients who have autonomic dysfunction, they then develop ventricular arrhythmias. And then when patients have ventricular arrhythmias, they're often treated either with an ICD shock or external defibrillation. And what this does is this results with an adrenaline surge that then worsens autonomic dysfunction that can then lead to more ventricular arrhythmias. There was a study published in the 90s that looked at adrenaline levels, circulating adrenaline levels pre and post shock. And what they had found is that patients who had received an ICD shock, their adrenaline levels increased threefold within minutes. And those who had received an external shock, their adrenaline levels had increased by tenfold. So again, this becomes a life-threatening cycle and patients can begin to spiral. So just reviewing or summarizing the pathophysiology, electrical storm is thought to be related to a triad of autonomic dysfunction, acute trigger, and a susceptible substrate. with each component having a variable impact on the development of electrical storm. And currently, or in terms of how we approach management, it's often based on treating each of these components of the triad of electrical storm. Now we'll move on to the evidence-based management. So I've listed here the common therapies that we use to treat electrical storm. Now each of these different therapies can treat a specific component or multiple components of the triad of electrical storm. The ones that I've included, the ones that we'll discuss in a bit more detail. But before we go there, I do want to talk about the quality or the lack of quality in the studies being done in patients with electrical storm. So our team had completed a systematic review that looked at the different therapies that were studied in this patient population, what type of studies were being done. And what we can see is that although we're publishing more over time in this field, the quality of studies are actually getting worse. Our sample sizes are going down over time. And we've only really published 4 RCTs in this patient population. 3 of them were published in the 90s, and then 1 in 2017 that only included 60 patients. What's then even more worrisome is that the therapies that we're studying are not the same as the therapies that are available to us. So on the table on the left, I've highlighted the 5 most studied medications in electrical storm. 2 of them aren't readily available at the bedside in Canada. And then if you take a look at the figure on the right, this is from a survey, a European survey of over 100 sites that actively take care of patients with electrical storm. And the most common medications that they have are not the ones that we commonly study, with the exception of amiodarone. So, one argument could be made is that with current electrical storm research, we've focused on more novel therapies, which are exciting, but there's a couple key things to highlight, and this comes from the survey as well. In terms of the sites that, again, actively treat electrical storm, 1 in 6 have a cath lab, 1 in 6 have an EP lab, 1 in 4 are not able to manage mechanically ventilated patients. 50% of them, 50% of the sites admit these patients to the general ICU, and about 1/3 of these sites are able to do a stellate ganglion block. So while, again, these are novel and exciting therapies that aren't readily available, and I think we need a better understanding of the foundational therapies to provide a greater impact to these patients suffering from this condition. So now we'll discuss the 3 first clinical trials that were published in electrical storm. Each of these studies had about a sample size of around 300 patients and are still the largest studies we have to date. So we've already briefly discussed these studies. These were the studies from the mid-90s. At that time, beryllium was the standard of care for treating acute recurrent ventricular arrhythmias, and IV amiodarone was kind of the new kid on the block. So they did a clinical trial, or what they did is they did a single clinical trial and published them as 3 separate clinical trials, comparing patients getting low dose, medium dose, and high dose amiodarone to those who had received beryllium, with their primary endpoint being the number of VT and VF episodes and the event-free time. Now, given that these studies are overall pretty outdated, we don't use beryllium anymore. I think one of them to highlight, though, is the one of the RCTs that was published that compared low dose amiodarone treatment protocols versus high dose amiodarone treatment protocols. So their low dose was 125 milligrams over 24 hours. As many of you know, when we get an amiodarone, we often bolus with 150 milligrams up front. So this is very low doses. And their high dose was about 1 gram over 24 hours. And with our current protocols and in CCU, it's not uncommon for patients to get 1.5 to 1.8 grams over 24 hours, or even their high dose is not as high as what we use today. But what they did find is that as you increase the dose of amiodarone, patients had less VT and VF events. But despite having better arrhythmic control, with the higher doses of amiodarone, there was no statistically significant difference in mortality in 48 hours. Moving forward to the most contemporary trial being the study that compared propranolol to metoprolol We've already also briefly discussed this study. They used the contemporary definition of electrical storm. And what they looked at is compared propranolol 40 milligrams POQID to metoprolol 50 milligrams POQID in addition to standard of care, which would have been amiodarone. The outcome of interest for them was the number of treated ventricular arrhythmias and freedom from recurrent ventricular arrhythmias. So they randomized 30 patients to get propranolol and metoprolol, and what they had found is that patients who received propranolol were less likely to have treated ventricular arrhythmia events and less likely to have ICD shocks. And really the benefit was seen after 6 hours the study drug was given. While patients were event-free from their VT faster with propranolol, when you compared them at 48 hours, there was no difference between propranolol and metoprolol. And some of the discussion around why there may be a benefit with propranolol probably falls into two hypotheses. One is that propranolol crosses the blood-brain barrier, maybe there's a bit of a sedative effect. And two is that in normal and structurally normal hearts, the beta 2 receptor ratio is about 80 to 20, while patients with structurally diseased hearts, that ratio is probably 60 to 40. And that having a non-selective beta blocker may be a better antiarrhythmic medication. Now, moving forward to catheter ablation, this on its own can be a whole topic, and there's been many studies published in this, but I did want to focus on one study that was recently published for the acute treatment of electrical storm. So last year, there was a propensity score matched observational study that was published in JACC EP that included 780 patients with electrical storm. They used the contemporary definition of storm, but when you take a look at their table 1, this was a predominantly refractory patient population, meaning that they had failed first-line antiarrhythmic drug therapies. The other thing that's important to know with this study as well is that this was a critically ill patient population. Cardiogenic shock was present in 20% of patients. Mechanical circulatory support was used in 10% of patients, and deep sedation, mechanical ventilation was used in 30%. The overall in-hospital mortality was 15%. They did a propensity score matched analysis to compare those patients who had electrical storm and received catheter ablation to those who were in electrical storm who were treated medically, to compare if there was any significant differences in their outcome. Now, the findings of this study are actually pretty interesting and surprising, to say the least. I think the expectation going to this is maybe we'd see a better arrhythmic response, but what they had found is that there was a significant reduction in hospital mortality of 60%. Now, I think they did a pretty good job in terms of developing their propensity score matching, but I think there's still residual confounding because this seems too good to be true, and I think because of how much residual confounding there is, you can't make really any definitive statements as a result of this study. Well, again, it's interesting. I don't think it's changed practice at this time. Next, I'll be discussing therapies that we often use for autonomic dysfunction, being neurohormonal modulation, sedation. So neurohormonal modulation has been hypothesized to be a targeted therapy for electrical storm and recurrent ventricular arrhythmias for decades. In this landmark study that was published by Dr. Nadamani back in 2000, he looked at patients who had presented with electrical storm, and these were patients who had an MI at least 72 hours. Had an MI during their initial index admission. They developed electrical storm 72 hours or more after their admission, and they failed initial antiarrhythmic drug therapy, and at that time they had called it their ACLS therapy, being doses or bolus doses of IV procainamide, lidocaine, and beryllium, who then required intubation and general anesthetics. At that point, he then compared the patients who had this ACLS therapy continued being ongoing antiarrhythmic drugs versus those who had their ACLS therapy stopped and sympathetic blockade was used instead, meaning IV beta blockers and stellate ganglion blocks. And his findings were quite interesting. He found that mortality at 1 week was 22% in those patients who were treated with sympathetic blockade versus 82% with the patients who were treated with ongoing ACLS therapies. And the study has really progressed our understanding of electrical storm. And this brings us to the stellate ganglion block. Now, this is probably, not probably, this is the most studied neurohormonal modulation technique that we see with electrical storm. So sympathetic innervation starts from the brain, passes through the stellate ganglion in the neck, and then innervates the heart. The premise behind this procedure is by injecting an anesthetic here in the stellate ganglion, we can suppress the hyperactivity of the sympathetic nervous system. Now, although we discuss this, relatively frequently, especially in the CCU, this is something we don't do very often. And the subspecialty that does do this the most are our colleagues from pain medicine. So here at the pain clinic in Ottawa, they'll treat a number of different pain syndromes, and morning in their clinic, they'll sometimes do like 8 to 10 stellate ganglion blocks. So they have much more experience. I think to really understand the evidence, there needs to be a bit of understanding of the actual procedure itself. Now, the standard of care to do this procedure is to do it all under ultrasound guidance, and it's quite similar to inserting a central line. So this is what we typically see on ultrasound when we're in the central line. You can see the internal jugular, the carotid, and all we really need to do for a stellate ganglion block is just zoom out. And I've highlighted here in red where the stellate ganglion sits. It's between the longest calling muscle and the carotid artery. Now, the stellate ganglion sits at the level of C7, but we often inject at the level of C6, and this is for one very important reason. The vertebral artery runs parallel to the nerves coming down the neck, and they're protected by the anterior tubercles of the spine. C7 doesn't have an anterior tubercle, so there's a higher risk of arterial puncture. So we'll just naturally inject at C6. And on ultrasound, we can differentiate the different levels, C5 and C6, with C6 having more prominent anterior tubercle called Chasniak's, which you can actually feel on palpation. And then here you can see in C7, there is no anterior tubercle. And what this looks like practically is that when you're holding your ultrasound, you introduce the needle from the side of the ultrasound, and you inject right between the longest calling muscle and the carotid artery. And if you've injected in the right spot, the carotid artery should displace upwards. Given that the stellate ganglion block also innervates the ipsilateral facial muscles, all patients should get a Horner syndrome. And if you speak to the pain physicians here, they say all the patients, when they leave clinic, have at least a partial response that they'll see before they go home. And if they don't see that, they're worried that they injected the anesthetic, or that they didn't inject the anesthetic in the stellate ganglion, which is an important concept to grasp before we talk about the evidence. And really, this is the evidence that we have for stellate ganglion block. So last year, the STAR study was published, which was a multi-center observational study of stellate ganglion block in the refractory electrical storm. This included 131 patients. Their primary analysis is the figure on the left, where they compared patients 12 hours before their first stellate ganglion blocks in terms of the number of ventricular arrhythmias they had versus the 12 hours after their last stellate ganglion block. Now, when you look at this data, it actually looks quite promising, but then when you take a step back and look at the type of analysis that they did and how they did their procedures, it raises more questions than it provides answers. For one, around 25% of these patients had more than one stellate ganglion. And when you're comparing the 12 hours before their first stellate ganglion block to the 12 hours from their last stellate ganglion block, that leaves a big window. You don't know what other treatments they got. This could include other antiarrhythmic drugs. This can include intubation. And most importantly, what's often not described in these studies is this also includes device setting changes. Often when patients become unwell with their electrical storm, we'll put a magnet on, and by definition, they'll have they'll turn off their tachytherapies and they'll have less treated events. So that's a huge confounding in terms of the analysis. Now, I do sound a bit pessimistic about the results, and that's because of how they did the procedure. So, as I said, the standard of care is to do it under ultrasound guidance. Around 60% of these were done blind, meaning they just felt for Chasniak's tubercle and they just inserted the needle into the neck. Again, not standard of care. The other thing is just around a third of patients actually developed Horner's. So what that tells me is that they actually, in most of the cases, they might have not actually injected the stellate ganglion. And these results or the findings, they're significantly confounding. Based on the combination of the two, what this really tells me is that, again, this doesn't really change practice, at least in my eyes, but we really do need a clinical trial to see if this procedure is beneficial. And that we should also probably lean a bit on our colleagues from pain medicine and learn how to do this procedure properly. And we also completed a systematic review on this topic as well, really highlighting the same findings that they had found as well. There was 20 studies that we found. All of them are before and after studies. None of them had comparator arms. Repeat stellate ganglion blocks were used in more than 20% of patients. But the one thing that's also really important is that this patient does suffer from a high in-hospital mortality, 20 to 25%. And given that stellate ganglion block was used, this is probably the patient population that is more likely to be a primary arrhythmic storm. And many of these patients also had advanced therapies. Now, just briefly discussing deep sedation, because there is much evidence for it. Deep sedation involves the use of mechanical ventilation and high dose sedatives to essentially turn off the sympathetic drug. And this is really safe for refractory electrical storms. So patients who are not responding to our initial upfront therapies remain critically unwell. In terms of the best study that we have is a observational study of 116 patients from France. And what they had found is that once they intubated a patient, within 15 minutes, half of the patients no longer had ventricular arrhythmias, and that it completely resolved. When you look more closely at the data, the mortality in responders was around 25%, and the mortality in non-responders, meaning those that had ongoing ventricular arrhythmias, was just over 50%. And the only predictor for being a non-responder was the presence of pulmonary edema. And in my mind, the way I justify this is that patients who respond to intubation are likely to be a primary arrhythmic electrical storm versus those who do not respond, or just have end-stage heart disease and are likely dying with electrical storm rather than dying from it. And so now summarizing the management, this is from the Canadian guidelines. Based on the evidence that we have, and again, this is now mostly based on expert consensus as well, the foundational therapy, the initial therapy for electrical storm is the use of beta blockers, preferentially non-selective beta blockers like propranolol and IV amiodarone. In refractory cases, we'll then consider sedation. We'll then consider anesthesia. You always look to also treat the underlying, if there is an underlying acute treatment, you'd like to treat that as well. Now I'll discuss some of the current studies that are being done here at the Heart Institute. So again, just as we've already reviewed this, but targeted therapies for autonomic dysfunction electrical storm are really reserved for refractory cases, given that they're can be quite invasive and intensive with the use of mechanical ventilation, or two, because they're not readily available or commonly used, like stellate ganglion blocks. It's unclear on whether treating autonomic dysfunction up front can break this vicious cycle or this kind of life-threatening spiral that we commonly think we see in electrical storm. And so we developed the study evaluating dexamethasone in the acute treatment of electrical storm, or the sedate trial, to see if early treatment of autonomic dysfunction improves patient outcomes. So dexamethasone is an alpha-2 adrenergic receptor agonist that allows for lighter sedation. And what I mean by lighter sedation is that it doesn't impact respiratory status, so patients often don't need to be intubated for this. It's run through an IV as a continuous infusion. It has a rapid onset of within 15 minutes. It's already a commonly used medication in the ICU and is found readily or worldwide. And there's lots of experience with this medication. When we take a look at the evidence behind dexamethasone and ventricular arrhythmias, there was a systematic review meta-analysis that was published that looked at patients who were sedated in ICUs and the number of ventricular arrhythmias they had. And in the observational studies that were included in the systematic review, they had found there was a lower risk of ventricular arrhythmias with dexamethasone compared to those who were receiving propofol or midazolam. They also included one study that was actually a clinical trial that compared dexamethasone versus placebo on top of standard of care 7 agents during cardiac surgery. And they also found a significant reduction in both atrial and ventricular arrhythmias. But when we discuss the electrical storm patient population and the evidence for dexamethasone, it really comes down to a single case report, and it's of a 12-year-old patient who's got refractory electrical storm. Storm was treated with Precedex with resolution thereafter. But really, we do have limited evidence in terms of using this medication. But despite this, it's a recommended agent in many reviews that are currently published, and even in the Canadian guidelines, is a preferred anesthetic for the treatment of electrical storm. So again, really our question now becomes, does the use of early sedation with dexamethasone improve in-hospital outcomes of patients with electrical storm? And so we designed a multi-center double-blinded randomized control trial looking at the use of dexamethasone versus placebo up front. We're stratifying patients based on whether they're intubated or not intubated, given that intubated patients are already on sedative agents, which can confound some of the effects. At that point, patients are randomized to receive dexamethasone or placebo, and they would be on treatment for 48 to 72 hours. This is on top of other standard care therapy. They would continue their antiarrhythmic drugs. If they need other forms of sedation like intubation for recurrent arrhythmias, that can still happen, of course. In terms of our inclusion criteria, we included patients who were 18 years of age and those who were admitted to an ICU with electrical storm. As many of you know, electrical storm is often admitted to reference center as well, so linked to step-down unit. By including only patients who are admitted to ICU, we're subselecting for the higher risk patients. In terms of the exclusion criteria, we excluded conditions that would indicate end-stage heart disease, again, where patients are dying with electrical storm and not dying from electrical storm. And in situations where there's other competing risks of death, like prolonged cardiac arrest, or in conditions where we would think that dexamethasone, or we would hypothesize that dexamethasone isn't as beneficial or potentially. Our primary outcome is all-cause in-hospital mortality, and or any in-hospital treated ventricular arrhythmia. And we define this pretty broadly as any ventricular arrhythmia that needed ATP, ICD shock, a defibrillator shock, initiation of an IV antiarrhythmic, intubation, things like that. For our sample size, this was a bit more challenging, truthfully, because the evidence, again, is so weak, and the studies that are published are either looking at long-term outcomes and less short-term outcomes. We estimated what the event rate would be. We thought it would probably be around 55% for both death and, again, recurrent ventricular arrhythmias. And in the placebo group, With an absolute risk reduction of 20%, we estimated we need 192 patients to have 80% power. So far, it's been just under a year. We're at like 10 or 11 months. We've enrolled 43 patients just at this one site here in Ottawa. We're hoping to get the Mayo Clinic and the University of Calgary up and running the coming months. And our in-hospital mortality is around 10%. And our primary endpoint is occurring about 45% of patients. So our estimate, again, was a bit of a guess, but it seems to be pretty close to what we're actually seeing. We're also doing an extension of the STATE trial called the State of Mind study. Now, I've kind of come to realize that these patients unfortunately suffer from high morbidity, given the fact that they're coming in with multiple ICU shocks that can be really stressful. And we know the ICU experience can also be really stressful for patients. So we actually haven't really defined in the literature what the morbidity in this patient population is. And when you take a look at different components of their care and their clinical presentation, ICU survivors can suffer from PICS, which is post-intensive care syndrome, which can manifest as a number of different things, including cognitive, psychiatric, and physical disability. Some studies have commented that there's up to a 2/3 chance of developing mental health illnesses such as depression, anxiety, and PTSD. And then when you take a look at the ICD patient population, mental health illnesses are also very prevalent. In patients who have ICDs alone, like not even including the fact that they've had an ICD shock, PTSD is found in 12% of patients, depression roughly 15%, and then anxiety 22%. And when they do have an ICD shocks, the prevalence is much higher. So that's the purpose of the State of Mind studies, that we want to investigate the morbidity in this patient population. The other thing that we thought would be interesting is that we were wondering if early sedation in this patient population would then lessen the trauma associated with the recurrent ICD shocks and potentially their experiences in the ICU, and if this also improves morbidity. So right now, Dr. Gabe Nelson and I, Drew Christian, we're following up with these patients 3 to 6 months post-discharge, and we're screening them for mental health illnesses and then assessing the quality of life. So just to summarize my presentation, electrical storm is a form of densely clustered ventricular arrhythmias that's classically thought to be related with high short-term mortality, but the patient population is much more heterogeneous than that. The current evidence for the management of electrical storm is quite limited. Again, we often rely on small studies or expert consensus in terms of the development guidelines. And one promising area of research is the management of autonomic dysfunction. And if we can target that, we can potentially improve patient outcomes. Before I finish, I do want to say something that what's really interesting to me is that the best studies that we have in electrical storm were published in the 90s. And I've always kind of wondered why. Having a chance to really reflect on the work that we've done over the last few years, I've come to realize that this patient population is unique in the fact that it needs collaboration between cardiac intensivists and electrophysiologists. Now, the cardiac intensive here they're obviously leaders with their work that they've done with the DORME 2 trials and the Minos trials. And the electrophysiology team here is obviously very experienced as well. And having those two teams collaborate, I think, has been a huge reason for why we've been successful so far with sedate. And in my eyes, it does place, I think, the heart in a position to be leaders in this field. So I did want to thank Dr. Matthew, Dr. DeSanto, Dr. Ramirez for all their mentorship. And I do want to thank all the residents. Recruitment wouldn't be where it is without you guys. So again, thank you so much.
Thanks, Pouya. Are there any questions from the audience, or if you want to type a question into the chat, we can answer your question that way. I'll ask the first question. Pouya, is there any evidence in the literature that looks at overdrive pacing or increasing base pace rate for these patients to treat this this problem.
Yeah, so as part of the systematic review that we did, just as a little bit of background, we were also including that as part of different therapy study. Our inclusion criteria was really broad, so we looked at essentially any patient population and hospital patient population that have recurrent ventricular arrhythmias, so not even using the contemporary definition of STORM. And we made the minimum threshold that the sample size needed to be 5 patients. We didn't find any studies that included more than 5 patients. There was case reports, but that was really it.
Thank you. Dr. Labanez has a question.
Great talk, great overview, great study. Question for you. Any data on MCS? You know, we've had a few anecdotal patients. I think Ben's had a few as well, where we put them on Impella and their ventricular arrhythmias seem to have improved, at least in the short term. What's the story in the literature about using things like Impella microaxial type of support for these people to, you know, like it has lots of beneficial effects and even allows you to up titrate drugs and things like that.
Great question. Again, the evidence is really limited. We see the prevalence or we see the use of it in electrical storm and we see how commonly it's used. Again, in patients with the refractory storm, 10 to 25% of patients will be on some sort of MCS. And whether the benefit is actually related to some sort of antiarrhythmic effect related primarily to electrical storm, I'm not sure, or whether it's just that you have really sick and dying heart, and these patients are suffering electrical storm as a result of that. And this is a way to support the heart and then kind of then terminates the electrical storm. I think that's likely the case. But to answer your question, there isn't any evidence at all for that.
Any other questions, Dr. Burney?
I think I'm a rookie. Yeah, this is fantastic. You know, this is exactly where we want to be. This will be another New England Journal paper, I'm sure. So great credit to Rebecca and Marina and the whole group. My question is, you're halfway through your first trial, so this is the time to be thinking of your next trial. So what's your next trial going to be?
That's a great question. I've actually started to think about it a little bit. From my understanding, I think there's another group that's looking at doing a clinical trial in stellate ganglion block. Depending on how that goes, I would like to do a trial with stellate ganglion block. But I think if, you know, and I'm hoping that there's obviously successful to that because that information and that data is needed. If that's not the case, I do want to see. I do want to compare different antiarrhythmic drugs for first-line therapies. So here, for example, when patients come in with electrical storm, we'll often put them on a beta blocker. Again, we follow the Canadian guidelines, put them on IV. But someone like the Mayo Clinic will treat these patients up front with dual antiarrhythmics with a lidocaine infusion plus amiodarone. So I'm hoping from the same trial, we'll be able to identify the high-risk electrical storm populations and completing a trial in that patient population, like compared to different antiarrhythmic strategies up front to see that if that improves patient outcomes or and if a more aggressive therapy up front would reduce the risk of them escalations in their care, things of that nature. So again, I do think that the antiarrhythmic drugs are the foundations of care for electrical storm. So I would want to build on the evidence for that.
Any other questions? Dr. Matthew?
I'm just curious if there's any data that you're aware of in terms of like subphenotypes between ES as a whole, right? We talk so much about HTE, like we've talked about this before in the lab meetings, if that's really being sussed out, or I don't know if Dan knows anything. And then following up from that, is there any plan to do biobanking where you could look at that on the back end?
This is something that I've been actually thinking about. I think obviously with some of the work that's coming out. There was an interesting study that was published in JACC EP, I want to say in the last 2 or 3 months, and they had measured neuropeptide Y levels in patients with electrical storm. Now, neuropeptide Y is found to be associated with Takotsubo, as an indicator of high sympathetic tone. And they found in this study that was published in JACC that patients who have refractory storm were much more likely to have higher levels of neuropeptide Y. So that makes me wonder whether there is a subset of patients who have a higher degree of autonomic dysfunction, and those are the patients that are more likely to develop refractory storm. I took a look on it to see if I could order neuropeptide Y just to see, just to see, if you can't. But that's something that, you know, I was actually thinking over the last couple of weeks, if that's something that we could potentially do. As maybe a sub-study to sedate, seeing if there's an additional benefit or if really a benefit with depressive is seen in those patients or they have more autonomic dysfunction. And to your point, with the phenotypes and electrical storm, spending more time with this data, I think we might need to step away more from maybe electrical threshold for the definition of what or storm, maybe lean more towards a phenotypes type data set. So saying that a patient has electrical storm if they have 3 arrhythmias in 24 hours plus one of these things, because then we're subselecting the patients who are more likely to have refractory electrical storm or more likely to suffer from short-term death. So whether they're refractory initial first-line therapy, whether they're presenting with heart failure, whether they come in with amiodarone. I don't know what those variables are, but that's something I'm planning on doing with the CC registry that we currently have, is to look at all the patients who are admitted with arrhythmias, with ventricular arrhythmias, and see who are the ones who have refractory ventricular arrhythmias, who are the ones who suffer from that, and kind of coming up with a risk stratification, essentially a risk stratification model, but a way to really define what storm is.
Just to add to that, first of all, great talk for you. Just to follow up to Rebecca's question, so I think you're totally right. I think the next one in my mind is the phenotype. We have more from that you present. You have mortalities of 0 to 50+%. They're obviously different patients, and from our perspective, one thing that if you look, we didn't specify even which drugs needed to be used, because a big question in my mind that we've debated tons of times is probably the most common scenario is a patient that's already comes on amiodarone. You know, does reloading a patient who's already, in my mind, failed amiodarone therapy that's not the same population in my mind. And we know that amiodarone use is already a marker of, well, in observational data, a marker of people who are going to fail first line or go on to have recurrent arrhythmia. So I think you're totally right. I'm hopeful that the data set that we get from this and, you know, get combined with other data sets with the work that's being done in ICU here to maybe pin down more the phenotypes of who's higher risk, who's going to just respond to your propranolol up front. And part of the rationale for making this study so broad is that DEX, I consider as, from a risk-benefit perspective, a very relatively low-risk medication, where even if it's a population who's likely going to respond, we're not being so aggressive with a medication up front that we otherwise wouldn't feel comfortable using. So anyway, I'll just say I think it's a great idea. And the other thing from a more an EP perspective is, I think we're going to hopefully sit down with a lot of the EGMs and interrogations, like almost all these patients have ICDs, and anyway, a ton of sub papers. So if anyone has other ideas of what we should be looking at, we're all ears.
Great. Are there any other questions? Excellent. Thank you so much, Pouya. That was a wonderful presentation. Have a good day, everyone. Please sign up for next week's presentation.